Okay, so firstly, just on behalf of Thorne Harbour Health, I would like to acknowledge that we're broadcasting this forum from the traditional lands of the Wurundjeri people of the Kulin Nation, and I'd like to pay my respect to their elders, both past and present, and recognize that this land was never ceded. And I'd also like to extend that acknowledgement to the traditional custodians of the land where all of you watching are joining us from for this forum. I'm Cal Hawk. I'm the Communications and Policy Manager at Thorne Harbour Health, as well as one of the producers and presenters of our weekly radio show on Joy 94.9, Well. I'll be moderating this online forum this evening, and joining us from, I believe, Gadigal country of the Eora Nation will be Dr. Vincent Cornelisse. Vincent is a specialist in sexual health medicine and manager of the medical unit at Curtin Road Centre in King's Cross, Sydney. Vincent's research focuses on sexual health epidemiology with an aim of improving the understanding of the current epidemics of sexually transmitted infections in order to develop more effective interventions. Now, tonight, Vincent is joining us to unpack some of the many questions we've received from the community about the monkeypox virus, or MPXV, while Thorne Harbour has received a number of questions via email and social media prior to tonight. I do encourage people joining us live to use the Q&A function to ask their questions, and we'll hopefully try to bring those in and answer as many of those as we can. Now, before we get into that, I also want to acknowledge that I know a lot of folks that are joining us tonight were kind of in a frustrating position. Many folks are wanting to access vaccine and unable to get an appointment, or they're just frustrated by the uncertainty as we're kind of wrapping our heads around the monkeypox outbreak. And Thorne Harbour is committed to supporting people to take control of their sexual health and the agency to do so. And we just kind of acknowledge that this is kind of an uncertain time for a lot of people. So hopefully we can give people as much information as possible tonight and stay abreast, because we are hoping to be able to make more announcements, whether that's, additional access to vaccination or, more information around reducing the risk of monkeypox in the days ahead. So now the current global outbreak of monkeypox really got underway in May of this year, and a number of resources have been released on the basics of understanding the virus. So to optimize the time we have for questions tonight, because we do have so many, we're going to zip through some of the basics. And so Vincent, if it's all right by you, we were talking amongst the team this morning. This is kind of like a previously on monkeypox, 60 seconds. And you can correct me if I get any of these details wrong. Is that all right? Okay, cool.
Yeah, suits me.
Okay, so in brief, monkeypox is a viral infection caused by the monkeypox virus. Previous to May of this year, occurrence of monkeypox was rare outside of Central and West Africa. Typically a relatively mild infection. Initial symptoms were similar to like the flu before progressing to a rash or lesions, particularly on the hands, face, and legs. And it was usually a self-limiting infection that the body would clear itself within a few weeks. Transmission was largely thought to be via skin-to-skin contact with lesions, through prolonged face-to-face contact via respiratory droplets, in contact with clothing, bedding, or used by someone with the infection. However, things have evolved, and now the CDC reports that there are now more than 44,000 cases around the world. 98% of those cases in this kind of more recent outbreak have been amongst men who have sex with men. And presentations of lesions have varied from those earlier outbreaks. And we're seeing a lot of presentations in the mouth, genitals, and anal region. And while the majority of those cases still continue to be relatively mild infections, 10% of those are moderate to severe. And in very rare instances, I think by last count, around 5 deaths have actually occurred globally associated with monkeypox. And those are in countries where the virus was not endemic previously. We do have a lot of basics on monkeypox that if you want to get up to date on that, we are updating our website. But if you head to the Thorne Harbour website, thorneharbor.org/monkeypox, we have a lot of those basics. But tonight, we really want to focus on where we're at right now. So yeah, we want to kind of dive right into where we're at. We do have vaccination options. I haven't mentioned those yet, and I want to unpack those with you, Vincent. But I guess, first of all, feel free to correct any of those details I may not have gotten quite right. But what to you stands out as being the real difference in this outbreak as opposed to our kind of historic understanding of monkeypox prior to this?
Yeah, Cal, great summary, first up. You got everything right. The big difference is, and just, I guess, to paraphrase some of what you've said, is that, as we know, for decades, we've had Mpox or MPXV or monkeypox in what's been termed endemic countries in Central and Western Africa. It's exactly the same, the transmission dynamics you've described. The big difference with the current outbreak, which started sort of in Western Europe and the US and then Canada, is that, as you said, this is very much affecting a specific population in those countries, and it's gay, bisexual, and other men who have sex with men. And there's been a lot of argument in the health sector around whether this is sexually transmitted or whether this is transmitted through close contact or transmitted through respiratory droplets. I think the debate is currently being settled, and I think most people are now on the same page in terms of treating this as an epidemic of sexual transmission. There's a few reasons for this. The main reason being that, as you pointed out, that 98% of cases are amongst gay, bisexual, and other men who have sex with men. And if there was a route other than sexual transmission, we would have expected to see transmission beyond that community. For example, if close contact transmission was a significant driver, then you would have expected significant transmission, for example, at dance events that are also attended by people other than gay, bisexual, and other men who have sex with men. Or if you don't mind, I'll change that term just for tonight to gay plus communities, just to save the words. And we haven't seen that. We haven't seen big outbreaks at dance events. And I think particularly in the context of having just come through Pride season in the Northern Hemisphere, where there have been massive amounts of large-scale events, and yet we're not seeing an outbreak spreading beyond the gay community, I think we can be fairly certain that transmission is through sexual transmission. If you then add to that most lesions, skin lesions that we see are either on the genitals or the in or around the anus or in and around the mouth, again, the parts of the body that are used for sex, that again adds to that picture of this being sexually transmitted. And finally, the question around respiratory droplets was sort of heavy on people's minds because that raises the stakes in terms of rapidity of transmission and sort of there's the broadness of transmission. And again, we haven't seen that. And initially during this outbreak in Australia, all of the cases were imported, as in they're all occurring in people who acquired MPOX overseas and then came back to Australia and then were diagnosed when they arrived here. All those people came on long plane flights. They all spent lots of hours in very close contact with lots of other people, sharing little plane toilets, and no one else on the planes got MPOX. So I think, I'm keen to put the baby to bed and say, look, we can stop worrying about spreads through respiratory droplets and other forms of close contact, and perhaps even fomite transmission being transmission by contaminating surfaces and then other people who touch those surfaces picking up the infection. I think we can sort of put the baby to bed with all of that and say, look, this is currently sexually transmitted in this particular outbreak. That's not to say that it can't possibly be transmitted through other circumstances, but that's not what we're currently seeing. And we need to focus on how do we find ways for people to stay safe, to be able to protect themselves and protect the people they have sex with. Sorry, I hope that answered your question.
Look, it has answered a few questions and it has triggered a lot more. And so we're going to kind of try to tackle some of those along the way. But yeah, I think 100%. Basically, to summarize that is that if you look at basically how this outbreak has happened, it's kind of undeniable at this point that it seems to be moving exclusively through sexual networks.
Yeah.
And beyond kind of the others. And I guess for us as a community organization, we're kind of prioritizing. We now have the challenge of trying to prioritize how to figure out how to reduce that risk in that way. And by kind of acknowledging those other ways is all well and good, but we kind of need to focus on where the risk is highest.
Definitely.
So with that in mind, and actually one thing I did want to ask you, my understanding is there is some research around the presence of the virus in seminal fluid. Is that right?
That's correct.
And we've known that for a little while.
Do you want me to start talking about that? Because
let's talk about it.
Let's go with it. It's a slightly different topic, but it's related. It's very much related. So, how do you transmit monkeypox? And I think we perhaps should talk about this a bit more broadly first. So, if and at some point we need to touch on the symptoms of monkeypox as well, because this is related. But we've got time, right? So, how do you transmit monkeypox? So, if you have lesions, skin lesions, monkeypox skin lesions, which if you need to see pictures, they're easy to Google currently because there's lots of examples online. But if you have lesions, then those lesions contain material that contains the virus. So direct contact with those lesions onto mucosal skin. So that's, for example, genital skin, skin of the mouth, including the lips, and the skin in the anal area. So like your actual butthole. That contains skin that's called mucosal skin, which is different from the skin on the outside of your body. It's not as sort of sturdy and not as impenetrable as So the skin on the rest of your body is much more impenetrable. Anyway, getting back to it. So if you've got lesions, skin lesions with MPOX, if you get that material that contains the virus and put that into contact with either mucosal skin, so again, genitals, anus, mouth, or if you rub it on a cut in skin that covers the rest of your body, then it can transmit that way. Now, what we've also, so that's from those lesions directly. And then to get to your point, what we've also found is that if someone has monkeypox, then their semen will contain monkeypox virus, which again highlights that this is likely to be a sexually transmitted epidemic. You've just lost all your light, Cal.
I have. So I'll just re-trigger that. So you keep talking.
No, you're right. I'll keep going. But so again, semen contains MPOX. If you are currently experiencing the illness of having monkeypox. Now, what to add to that? So you can transmit it through exposure to skin lesions. You can transmit it through exposure to semen or probably pre-cum, vaginal fluids, saliva, any sort of bodily fluid during an active infection. Now, once you've recovered from an infection, which as you pointed out, may take a couple of weeks, it might be 2 weeks, might be 3 weeks, might be 4 weeks. I've heard of a couple of cases of it taking 5 weeks, but I think the consensus is that generally it will take about 3 weeks for people to recover. And by recover, we mean that the skin lesions have healed. So the scabs that are formed on the skin lesions have had time to heal and they've fallen off by themselves, and the underlying skin has regenerated, forming normal, healthy skin, possibly with some loss of pigmentation. So when you've recovered and all the skin lesions have healed, your semen can still contain monkeypox for possibly 8, possibly 12 weeks after that. And the reason for that, and this has been found, there was a study in Italy that looked at this, and they looked at, they tested the guy's semen after they'd recovered from monkeypox, and they found monkeypox virus in there, which of course raises the risk that you could still transmit monkeypox by exposing other people to your semen after you've recovered from the infection. And the reason for that is probably, and it's getting a little bit technical, a little bit scientific, but the reason is probably that the testicles are kind of separated off from the rest of your immune system. And there's a good reason for that, because your testicles are full of semen, and your semen is are cells that are a bit, the little swimmers are little cells that are a bit different from the other cells in your body. So your immune system could recognize those as not being your own tissue and then attack them, and resulting in infertility. So in order to stop that happening, your testes are formed in a way that stops the immune system from getting in there to protect the semen. What that unfortunately also means is that if you've got virus in there, your immune system can't get into your testicles to clear the virus out. So that's probably why for a further 8 to 12 weeks, you might have a monkeypox virus in your semen.
We have had a couple questions come through just on that area. So just to clarify, because some of these I think are probably really short answers. So someone wanted to clarify, so can it be transferred to non-mucosal skin?
So it can be transferred to non-mucosal skin if that skin is not intact.
Okay.
So it's probably unlike, and I have to say, there's a caveat to everything I'm saying today, and the caveat is that a lot of, and I will do my best to, whenever I'm saying something that is not based in evidence, to point it out, but there's a lot of emerging evidence around what we're talking about today. So I'm really keen to be clear about what we know and what we don't know. But it seems so far that, and again, this is yet to be backed up by solid data, but it seems so far that it will probably not transfer to skin that is intact. It's probably only going to transfer to skin that has some sort of abrasion. And here we're talking about skin on the body rather than genital or anal skin or in the mouth. But the problem is that an abrasion can be a micro abrasion, so it could be skin trauma that's not sort of obvious enough for you to see.
Yep. Another question that came through when we were talking about mucosal skin, would that include like vaginal tissue?
Yes.
Okay, cool. And with regard to, we were talking about the presence of semen, what do we think when it comes to things like pre-cum?
So pre-cum is probably, we should probably treat quite differently from semen in this context. So I think during an acute monkeypox infection, so if you're unwell with monkeypox, then yes, pre-cum probably contains monkeypox virus. And of course, the advice from public health is that if you have monkeypox currently, please abstain from all sexual interaction, because in that scenario, when you have active monkeypox infection, your bodily fluids are highly likely to contain monkeypox virus, and hence you don't want to expose other people to that virus. So pre-cum is likely to be infectious during an active monkeypox infection, but it's not likely to be infectious after you've recovered from your monkeypox infection, unlike semen. So pre-cum doesn't come from your testicles. It's really the testicles that are shielded from the immune system, and that's probably why semen remains infectious.
Okay. Another one here that has just come up is around, we did touch on this earlier around there's some evidence that monkeypox can be transmitted through the air, as well as skin-to-skin contact. Is this less likely, or how likely is this? And I guess a lot of folks, when they hear respiratory, they get concerned too because of airborne viruses, like when we discussed COVID.
No, exactly. And that was certainly the concern at the start of this outbreak, because it was an unknown. We really didn't know whether it was airborne or whether it was respiratory droplets. And then the airborne was ruled out pretty quickly, because otherwise we would have seen really widespread spread really quickly. But then the question was around large respiratory droplets. So there was concern that people could transmit monkeypox through large respiratory droplets, which would mean that close physical contact, for example, dancing next to someone who's talking to you like loudly and kind of, there's respiratory droplets being formed, that could be an issue. I think we're now moving away from that as well, in that, again, we haven't seen these sort of large-scale outbreaks at large events like dance events. So I think respiratory droplets is an unlikely transmission route. I can never say it's zero risk, but it certainly seems unlikely. And again, it seems like, based on all the evidence that I described earlier, that we're very much looking at sexual transmission. So direct genital to anus, genital to front genitals, genital to mouth, that sort of mouth to anus, and all of the permutations, that's the transmission we're looking at as being an issue.
So I guess when we come back to, we have seen a lot of the messaging talk about fomites, and, should we still consider sharing bedding or towels as an infection risk?
So again, fomites, so just to give a bit of backstory, so monkeypox virus, or MPXV, is an orthopox virus, as you pointed out at the start. It's related to smallpox. Smallpox has been eradicated, other than a couple of biowarfare laboratories that keep smallpox stock for nefarious purposes. We know from smallpox that smallpox can survive outside the body for a long time. So if you have a smallpox scab and you shield that from detergents, and you shield that, as in you don't expose it to detergents and you don't expose it to the sunlight, then smallpox virus can live in that scab for decades. So that's where the risk around what we call fomite transmission came from. And fomite transmission refers to transmission through shared surfaces, bedding, toilets, bathrooms, that sort of thing. And certainly at the start of the epidemic, the advice to people who were isolating with monkeypox was, don't share a bathroom, don't share a kitchen, don't share any bedding. Be really careful when you're sharing a house with someone. That advice is changing. Again, we haven't seen fomite transmission occur in reality with monkeypox virus. We're still, of course, saying, it'd be good to be careful, but the reality is that monkeypox virus seems quite easy to kill with detergents, or even with ultraviolet light, as in sunlight. So if you wash your bedding and you hang it up outside, if there was monkeypox virus on there, it would kill it. It's probably, I don't know, sorry, Cal, what I've been thinking about is, what should we advise people around having casual sexual partners in your bed? I would say with that your risk of transmitting or catching monkeypox from someone via your bed sheets is probably much lower than the risk you have from having sex with that person. So if you invite someone to your bed to have sex with, you're probably more likely to catch the monkeypox from the act of sex rather than via your bed sheets.
All right. Well, I guess considering that, a couple other questions that we've had earlier is folks were thinking about, should we start, I guess, getting a little bit creative here? I mean, in the same way that we saw people, as they approach casual sex during COVID or coming out of COVID, are we, things like glory holes or using condoms as a barrier, are those things, do they have any potential for risk reduction when it comes to monkeypox?
I think they do. I think the risk reduction conversation is a really important one to have as a community, informed by evidence. I think, firstly, it's much less contagious than COVID. Again, COVID is an airborne infection or airborne virus that's much more easily transmitted. So I think we could be creative about this and find ways that people can have intimacy without, and while reducing their risk of monkeypox transmission. I think condoms can play a role. Condoms are not going to be 100% protective against monkeypox virus. I think that's really important to point out. I think given the, that you might be able to transmit it through saliva, you might be able to transmit it through pre-cum, there's lots of ways that you can have sex. And I think we have to be careful to not say that condoms are going to be massively effective at reducing the risk of monkeypox. What they will be, there's a couple of scenarios that I've thought of in which they will be effective. One is, if you want to avoid getting monkeypox up your bum, which is really uncomfortable. So monkeypox lesions are very painful or can be very painful. And as you can imagine, if you have a few monkeypox lesions up your bum, that causes significant discomfort and makes it difficult for you to pass bowel motions. And that's one of the tricky scenarios that we deal with clinically when we're trying to assist people in managing their monkeypox infection. So if you want to avoid reducing your risk of getting monkeypox up your bum, then it's probably, and if you like bottoming, then it's probably a good idea for at least temporarily, start using condoms for receptive anal sex or for bottoming, just to reduce that risk. It might not reduce your risk of getting monkeypox overall, but it might change the location where you get your monkeypox, which might significantly change your experience of monkeypox infection. I think that's one consideration. I had another one, but now it's just slipped my mind.
That's quite all right. Look, I might come back to you. One question that came up here is around, we were talking about transmission and things like beds before. We've heard one of the eligibility criteria for getting the vaccination. And I don't want to get into the vaccination yet because that's a whole other string of questions. But I guess with regard to surfaces, do we know anything when it comes to the transmission of monkeypox, say through something like water in spas or swimming pools and steam rooms, in those kind of like sex on premises venues?
So the public health units are working closely with sex on premises venues because that has been a concern. And I think given what we know about the risk of fomite transmission, as I said, if we're talking about in your bedroom, the risk of transmission via bed sheets is probably negligible compared to transmission directly through sex. But I think in settings like sex on premises venues, it becomes a more significant consideration. And I know the public health units have been talking to sex on premises venues about their cleaning routines to reduce that risk of spread via surfaces. Again, as I said, monkeypox virus is easily killed by detergents that we use for cleaning surfaces. So it should be a very manageable risk, but it is an ongoing conversation.
Okay. One of the other things that we wanted to ask was, someone said, how long is it viable outside of the host? And I suppose that does really depend on a whole range of circumstances, but I guess, it sounds like here, it kind of depends on where it's landed, so to speak.
Yeah, exactly. And as I said, there's documented survival of orthopox viruses for decades outside a host. But that is in, like I said, in very specific circumstances, as in within a scab, within a skin scab that's not exposed to sunlight and is not exposed to detergents. Again, just want to point out that even though the virus may survive under specific circumstances outside the host, we haven't seen significant numbers, or we haven't seen any transmission that I'm aware of people picking it up from surfaces. Like mean, there's been a lot of effort into contact tracing, as in talking to people's sexual partners and working out whether, and testing them and seeing whether they have monkeypox infection. And there have only been a few instances where it's been unclear where the infections come from. So I think it's fair to say that the chance of transmission from services and the chance of this virus surviving for a long time outside of a host in normal circumstances is pretty small.
Okay. Look, I think with surfaces, I feel like it's a pretty low risk. There's a lot of those questions coming kind of through here, but I guess I do want to move on to we started talking about prevention methods. At this point, should we be thinking about, if people haven't been able to get vaccinated in particular, but, I guess more broadly, should we be thinking about limiting our partners at this point? Because we know in health promotion, asking people not to have sex is kind of a pointless message to some extent, because kind of doing that indefinitely is not really part of our human behavior, so to speak. So what do you think about that? I mean, should we be thinking about using like really closed networks of people, we talked about the term fuck bubbles during COVID, where you might only have sex with a group of 6 people or something like that. I mean, what are your thoughts on that regard around reducing risk?
I think this is a really important conversation for us to have as a community. I have an answer for this. I just want to preface it. Sorry, I keep prefacing my answers with lots of
Quite
stuff.
all right.
But I want to preface it by I guess talking about, well, I think good news. There is a little bit of good news, and I think this is really important. So the good news, and it's early news. I don't want people to be too invested in this, but it looks like in the UK and in Europe, mainland Europe, case numbers have started to peak, as in they're starting to plateau, and even that is a suggestion that they're starting to drop off. And I think this is really important. I think it suggests that this may be a short-lived epidemic if we keep at it, if we keep working on it, if we keep working on prevention strategies, including vaccination, but perhaps also behavioral changes, temporary behavioral changes. And the reason I think this is so important is, as you pointed out, it's impossible for people to change what they do in terms of their sex lives and their intimate partners on a long-term basis. People have sex because people need to have sex. So one of the realities of life, and you can't ask people to stop having sex for a long period of time. What I'm hopeful for is that over the next few months, we'll see this drop off and we'll see this contained, and we can start to return to normal, as in have the sex lives that we wanted to have before monkeypox came along. Granted, many people already haven't had the sex lives they wanted to have for a long time now, thanks to COVID. So I think that's really important. And in that context, I think there would be a role for people thinking about how they might reduce their risk from a sexual partner number point of view, and also from the point of view of what sort of sex they engage in. Of course, there are ways to be intimate that don't necessarily share as much bodily fluid as other ways of being intimate. I'm sure I don't need to tell anyone, what the options are. But I think as a community, I think we should think about this and, think about, what can we do realistically in the short to medium term to reduce our risk and to reduce the risk to the people we care about, with hopefully the view of this not going on for a long period of time.
Okay. I want to ask you, I'm probably going to do this a couple of times because I'm mindful of time. We're about halfway through already here. I'm going to ask you some that I think have relatively short answers. So we might do these thick and fast. And feel free to just, give a quick answer. And
I'll try and give a quick answer.
As quick as we possibly can here. Okay.
Sorry, this is a kombucha, not a beer, just so you don't think I'm...
Oh, yeah, no, absolutely, 100%.
Yeah.
Someone's asked about gestation. I think they mean incubation period. What does that typically look like?
Okay, really important question. If I may, I'll take a little bit longer because I think this ties into symptoms as well. So I might as well just hammer home or quickly talk about incubation periods and symptoms, because I think it's important for people to know what to look out for. So the incubation period is a problem in that it can be short. We've seen it, they report within sort of 5 days, or up from 5 days onwards, you can start to get symptoms, but we've seen it be even shorter in some cases. So 3 to 4 days after exposure, people develop symptoms. but it can take up to 3 weeks for people to develop symptoms. And that's really important and really difficult to navigate. As in, if you've been contacted by someone and they said, look, I've been diagnosed with monkeypox and we've had sex, so you might have been exposed, then people need to think about, okay, this might take 3 weeks to show up. And it's really important, I think, in that scenario for people to seek medical advice around what they should be doing, sort of what testing they should be doing, or what testing they could be doing, and what they may need to do in terms of reducing the risk of spread to others. So having said that, so the incubation period is anywhere between, quoted as anywhere between 5 to 21 days, but it might be shorter.
Okay.
And then the symptoms that come on, this is where I'm going a bit longer. So classically, people first develop with what we call systemic symptoms or prodromal symptoms. So that's fever, and usually a high fever over 38 degrees, headaches, muscle pains, joint pains, back pain, and swollen lymph nodes. And the lymph nodes tend to be quite big. So these are the glands, for example, in your groin or under your armpits. But classically, in this outbreak, we're seeing it in people's groins. They go big, as in golf ball size, and they're painful. So that can be sort of part of prodromal symptoms. And then the other symptoms, so that's one set of symptoms, and the other set of symptoms are the skin lesions. Oh, sorry, I should point out, as you pointed out, with the prodromal symptoms, you can have a sort of a generalized body rash, typically arms, legs, face, rather than on your trunk. That's all prodromal symptoms. And the other set of symptoms are the skin lesions. So these, as I pointed out before, tend to occur either on your genitals, in or around the anus, and in or around the mouth. And they can be a range of different lesions. So they can be little red dots, they can be little blisters, they can be little pustules. So pustules are blister that's filled with pus, through to scabs, sores, ulcers. So a whole range of different possibilities. They tend to be painful, and they tend to be painful out of proportion of what they look like. So they might be quite small.
Someone wanted to ask that, on a scale of 1 to 10, how painful are they? Yeah.
Yeah, so people have reported 10 out of 10 pain from these lesions. Sometimes needing strong painkillers, like opioid painkillers.
Wow.
So, and the reason I'm bringing all this up is that I think it's really important for people to be aware of these symptoms, because if you notice any of these symptoms, and you don't have to have all of them, but if you notice any one of these symptoms, I think it's really important that you go and see either your GP, if that's the GP who's experienced in HIV and sexual health, or your local sexual health center, to get some advice and get some tests done, so that you know whether or not it is monkeypox, and if it's not monkeypox, what it is.
Okay, another question that is related to this: symptoms. Can you be asymptomatic?
So again, there's work looking into this. There's been a couple of studies in Belgium and France with differing results. What they did, just very briefly, they've obviously got a big outbreak there. They've tested a lot of people for monkeypox, but they've also tested a lot of people who didn't present with monkeypox for their usual STI screens, and getting butt swabs and throat swabs and urine tests done. So they went back and they just got all those non-monkeypox samples that were tested for STI screens, and they've retrospectively tested them for monkeypox. And they've estimated, again, the numbers are different in Belgium and France. In Belgium, they estimated that perhaps 1% of monkeypox cases are asymptomatic. And in France, they thought it was closer to 5%. Point of the story is the asymptomatic rate is really low, but not zero. So it's unlikely that for people to have asymptomatic monkeypox infection. But if you've been told that you are been in contact with monkeypox, then again, it's really important to seek advice from a healthcare provider to work out whether you should be tested. Sorry, Cal, can't hear you.
Classic example there. I was trying to, mute myself to make it make sense. Lots of questions rolling through here. A lot of questions are starting to look at. I'm going to ask you one more that I think might be relatively quick. Someone asked, how long is it viable, say, inside a host? And what they mean by this is, if they fuck someone who, let's say they're having a three-way, someone else comes inside a bottom first, and their cum is inside that person. If they are the next person to fuck that bottom, does someone do they have a risk of acquiring monkeypox through that?
I don't have any studies to back this up. Maybe someone should do one, but I'm sure some people would volunteer for it. But I would say, based on what we do know, is that yes, that would be a transmission risk.
Okay, and this is another one question that came through that I think this is relatively, you've already sort of touched on this, but oral sex, does that reduce the chance of contraction, or is that it's probably in the same ballpark as anal sex?
No, it's probably in the same ballpark. And we've seen lots of people get oral lesions, monkeypox lesions. Again, there was a study that came out of Spain a couple of weeks ago that looked at, it was a really neat study. They looked at where people got their monkeypox lesions and then related that to their reported sexual practices in recent times. And they had, I think, 19 guys who had monkeypox tonsillitis. So they had monkeypox lesions on their tonsils, again, very uncomfortable. And 95%, so 18 out of those 19 guys had performed oral sex on someone at the time of their monkeypox acquisition. So unfortunately, oral sex is having only oral sex doesn't reduce your risk of getting monkeypox.
Okay. One other question that has come through is when we were talking about contact surfaces before, and then we're going to move to vaccination here, was someone was saying, that for people that are working as like massage therapists or waxers or, barbers and things like that, is the risk relatively low, or should they be considered high at risk because they're having physical contact with people's skin, et cetera?
Sure. And I'm assuming you're here referring to non-sexual massage therapy.
Yeah.
Because I think that's obviously different question. I had this conversation with my physiotherapist last week because he asked me this as well, because we were talking. I see my physiotherapist every week for a shoulder issue, and he works in Darlinghurst. He's a heterosexual man, and we were talking about monkeypox because that's the sort of thing we talk about. And he asked me exactly the same question. He's like, as a physiotherapist in Darlinghurst who sees mainly gay men, what is my risk of exposure to monkeypox? My answer to him was, I would think it is extremely low. If you're providing a massage to someone, then you would notice monkeypox lesions if they were there. And again, it would be that direct exposure to the lesion, and you would need to expose some of your non-intact skin to that lesion to feasibly have a reasonable or significantly high risk of transmission. So I think that's unlikely to occur. So yeah, certainly, if you're giving a massage to someone and you notice some unusual lesions, then it would be worth having a conversation with that person around what might be going on for them, because they might need to seek healthcare. But I think in sort of day-to-day massage therapy or physiotherapy, in this case, the risk would be really low, and we're certainly not recommending monkeypox vaccination for health workers because it's deemed that the risk to health workers is extremely low. In fact, there hasn't been a single documented workplace transmission of monkeypox virus from a patient to a healthcare worker.
Oh, there you go. We want to get into the vaccine because there's been a lot of questions about the vaccine, and of course that's out there. Now, I am mindful too that a lot of people have asked questions around how can I get the vaccine? How can I, when is more of it going to be available? And I realize you do not work for, in that capacity around making.
Yeah, I'm in a different state, but
yes.
Yeah.
But so we won't be kind of delving into that. I will address that sort of at the very end of this. But I guess when I talk about the vaccine, at the moment we're hearing around, that there's the Jynneos vaccine or Imivune vaccine, depending on where you are in the world when you're getting it. Can you explain, before we talk into the variations of how it's being put out there, what that's been approved for, or how that vaccine typically works?
Sure. So the MVABN vaccine, or one of the brand names that you mentioned, is what we call a third generation vaccinia vaccine. So what that means is it contains a virus called vaccinia virus, which is a virus that doesn't normally transmit to humans. But it's a third generation, and the big difference between this third generation vaccine from the previous second generation vaccine is that this virus that we use now as part of the vaccine cannot replicate inside the human body. So it's not able to replicate, which means that it's very safe because it can't cause an infection inside the person it was given to, and it can't be transmitted to another person, which the previous vaccine could. So the previous vaccine came with a lot of problems, a lot of potential side effects and complications, including things like myocarditis, eye infections, overwhelming sort of skin infections. This new vaccine doesn't come with any of those risks. It was approved for prevention of smallpox, and many countries around the world were looking at, or some of the stock around the world that was being kept with this vaccine was as a bio warfare prevention strategy, in the case of a bio attack using smallpox virus. As you said at the start, or I think I said at the start, monkeypox is closely related to smallpox virus. It's an orthopox virus. So we're using a smallpox vaccine, or a vaccine that's been developed to prevent smallpox, to now prevent monkeypox. It works by, again, it's an injection that goes under the skin. So the licensed route of administration is as a subcutaneous injection. So it goes through the skin into the fat layers under the skin. And then that's repeated at least 28 days later. So it's a 2-dose course. If people get it more than 28 days later, that's fine. It's just that the minimum interval is 28 days. And then once you've completed the full course, then hopefully you have adequate protection. The reason I say hopefully is that we haven't previously had the opportunity to study the clinical effectiveness of this vaccine for monkeypox prevention, because we haven't had a scenario where we've had significant numbers of monkeypox in the community to be able to work out whether people are being protected with this vaccine. And that work is currently ongoing. So there's certainly a lot of work looking at how effective is this vaccine clinically. What we do know is that this vaccine produces a significant antibody response. So we know that if it's injected in people over a period of about 2 to 4 weeks, they'll start to produce antibody levels to the vaccinia virus, which should be protective against monkeypox virus. And importantly, the antibody response is slightly different for people who are living with HIV versus people who are not living with HIV. So firstly, for people who are not living with HIV, if they get this vaccine, they can expect a significant antibody level after about 2 weeks. So about 30% of people will have what is thought to be protective antibody level after 2 weeks. And about 65 or so percent of people will have a protective antibody level after 4 weeks or 28 days. And then, of course, the idea is that beyond that, you then get a second dose, and that second dose will probably take you up to a point where about 96 to 98% of people will have protective antibody levels, which we presume translates to clinical protection. That's for people who are not living with HIV. For people living with HIV, they also eventually get to that exact same protection level. It just takes longer. So they don't have as significant a response to the first dose generally. And then they have a second dose, and then eventually, after say 42 days, they should be at the same level of protection. And I think this is really important for people to know, that if you get the monkeypox vaccine, which I hope all of you will have access to in the near future, then you're not immediately protected. So the first dose will give you some protection after 2 to 4 weeks, and then the second dose will take you up to sort of maximal protection.
With that in mind, you did touch on one thing there around when you get the vaccine. Do we feel like some people were they going to experience soreness or a lump or whatever on the site of injection? And what can folks expect, and how long does that take?
Yeah, sure. Most people are fine. Sorry, I forgot what the actual percentages were. But soreness doesn't tend to be a major issue. It's a subcutaneous injection rather than an intramuscular injection, so it doesn't go into your muscles, so it's less likely to produce local soreness. Side effects, so general side effects, include things like feeling tired, maybe a fever, headachy, and that usually occurs the following day, and usually doesn't last more than a day. I think there have been a few cases of it lasting up to a week, of people just not having their normal energy levels. But that's really about it. There was concern about myocarditis. So as I pointed out, the second generation vaccine that was previously used had a risk of myocarditis. So there was some uncertainty about whether this vaccine would run the risk of myocarditis. And just for people who might not know, myocarditis is inflammation of the heart muscle. Now, the reason this is important is that this is a known side effect of COVID vaccines. And we've had a few people in our community who've experienced myocarditis as a result of the COVID vaccine. So part of the concern was, if you've had myocarditis from a COVID vaccine, is it safe for you to have a monkeypox vaccine? Now, we ran a vaccine hub here in Sydney where we vaccinated 250 to 270 people a day with the MVABN vaccine. And that was one of the conversations we were having with people when they were coming in. They're checking, have they had myocarditis before, or have they had a COVID vaccine before? To cut a long story short, it doesn't actually seem to be a significant issue. So when they ran the licensing trials for this vaccine, they vaccinated about 9,000 people to check for side effects, and there was not a single case of myocarditis. There was one person who possibly developed pericarditis, which is inflammation of the membrane around the heart, but it was just a possible diagnosis, so not anything significant. So my advice to people has been, as long as if you've had myocarditis from, for example, the COVID vaccine, as long as you're fully recovered from that and have no ongoing symptoms, you're safe to get the MVABN or monkeypox vaccine.
Okay. One of the things that we're hearing, I'm just mindful of time here because we kind of told people that we'd be wrapping up here within an hour. Oh, no, quite all right. We are hearing around the CDC and also in the UK, they're using a slightly different way of applying the vaccine. Can you explain how that's different, and are we going to see a difference in efficacy?
So really important questions. So just as a bit of background, so this is all come about because we don't have enough vaccine, right? The whole world doesn't have enough vaccine. There's one company in the world that makes this vaccine and they haven't made enough of it. So we're all scrounging around trying to work out how are we going to provide enough vaccine to the communities that need it. And so one of the ideas that came up was we can change the way that we give the vaccine. So as I said before, the standard and the licensed method of giving the vaccine as a subcutaneous injection under the skin, there is an alternative way to give the vaccine, and that's into the skin. So within the skin layer, so very superficial, with a teeny tiny needle, and then you inject a small amount of vaccine just under the skin so it forms a little blister rather than going underneath the skin. And if you do that, you only need a fifth of the volume of the vaccine, which means you can vaccinate 5 times as many people. So it's a really important question because it means that we all of a sudden have 5 times as much vaccine to give out when we have a limited supply. Now, this is, of course, this is not what the vaccine was licensed for, but there was a trial looking at what we call immunogenicity of the vaccine, and they compared with this vaccine, they compared subcutaneous dosing with intradermal dosing at a fifth of the dose and found a similar antibody response. So it looks like it's just as effective. And the theoretical basis underneath, sort of underlying this, is that inside the skin layers, rather than underneath the skin, inside the skin layers, there are lots of immune cells, including cells called antigen presenting cells. And this is a bit technical, but basically they have a really important role in picking up sort of foreign bodies, foreign materials and infections, and presenting those things to the immune system in order to mount an immune response. So as you can imagine, if you inject a vaccine into that situation where there's lots of immune cells inside the skin, of course, you're more likely to get a stronger immune response to a small vaccine dose. So the thinking is, if we do this, we can vaccinate 5 times as many people and get the same immune response in those people as we would have got with the standard dosing.
Well, considering a lot of folks who are already on this call are aware that we have a incredibly low amount of the vaccine here in Australia, we might see that as a development, hopefully in the near future. And so if folks do hear about that, that shouldn't be alarmed. It sounds like all the evidence points to the fact that this is going to be just as effective. It's just kind of it sounds like a more technical application of the vaccine.
Yeah, exactly. So it does present some workforce challenges in that there aren't a lot of nurses who are trained in intradermal vaccine administration. So this is something that's very live at the moment and very strongly considered at government levels to work out, are we going to do this? Are we going to do this with the next supply of vaccine when it becomes available, probably in mid to late September? And if so, how are we going to get the workforce ready to be able to administer the vaccine in this way? So I wouldn't be surprised. I can't speak for government, but I wouldn't be surprised if this is the way we end up going in September.
Okay. So, and as you mentioned, there has been word that there's more stuff coming in September. But if the guidelines change in the near future, maybe this is something that can be applied to what limited supply remains so that we can maximize it into more arms. A lot of people, as you've mentioned, it's a 2-shot vaccination, but a lot of people have been successful in getting their first shot, and they might be successful in getting it in sort of the days and weeks ahead. How important is it around making sure that second shots get in arms? When does that become particularly vital? Like you said, a lot of people have to wait 28 days anyhow. Is there any strategy we've seen in Canada and the US that they're kind of just focused on getting 1 shot? And some people have even been told, especially if they're not HIV positive, that, just wait to get your second shot until there's more available.
Yeah. So I guess a couple of points to consider. From an epidemiological standpoint, if you're looking at the population and you're trying to maximize the protection of that population, and you've got a limited supply of vaccine, and you have a two-shot regimen, two-dose regimen, and you know that a one shot gives partial protection and two shots gives full protection. From an epidemiological standpoint, you're probably better off giving one shot to everyone than two shots to half the people. As in, you've got a much better chance of controlling spread if you give one shot to everyone. So just keep that in mind. Having said that, I'm still keen for everyone to get two shots, particularly keeping in mind that World Pride is coming to Sydney in March next year. And I think, and this is very much on government radar as well, that we really need to do everything we can to make sure that our community is as best protected as possible before March next year. And that means getting two shots into people's arms and getting that first shot and then second shot in well before March, because their immune system needs time to form antibodies to be protected by the time World Pride comes around.
That being said, you touched on this before, but I will just emphasize in case people haven't put those two things together. You said you have to wait at least 28 days for that second shot. But if it is 2 months before people can get that second shot, they're not at a greater, like the first shot hasn't become weak enough that, you know,
No. In fact, it's probably the opposite. So it's probably for long-term protection, you're probably better off waiting longer. So the 28-day period is very much a minimum period that you should wait between your first shot and second shot. If it's 2 months or 3 months, it's fine. I think it's just important that people get that second shot before they are at increased risk of being exposed to monkeypox, for example, during World Pride.
If someone, I'm going to throw this at you because we've had a couple of people talking about traveling interstate, traveling overseas. You know, one person said, if I've had one vaccination, is the second one as important before I travel overseas, or should, you know, protection from first vaccination be enough? I'm going to throw that question at you, but one other, because a lot of people recently traveled to Montreal for the AIDS 2022 conference. And Montreal, for instance, has enough supply that they've been able to offer it to visitors. So, you know, if someone can get a shot overseas, should they do it? And, you know, also too, or should people hold off on traveling if they've only got one shot or no shot?
Yeah, so I guess okay, I'm going to do my best to answer this as truthfully as possible. Not that I've got any inclination to be not truthful, but there's just some unknown. So I think, so as you pointed out, if your only possibility of getting a shot before you go traveling is getting a single shot, then I'd certainly suggest that you do that. But keep in mind that that's only going to give you partial protection. As in, it's going to give you partial protection from getting monkeypox in the first place. What is important to point out that if you do get monkeypox and you've had your one shot, you're probably much less likely to get severe monkeypox symptoms because you've got some partial protection, which I think is important. Like, I think there's a big difference between getting really sick from monkeypox versus just getting a couple of skin lesions. And if we can achieve that with a single shot, then I think we've achieved something. Sorry, what was the second part of your question?
Oh, and if you can get the shot overseas, should they do it?
Oh, yeah. So, of course, I'm not in the position of providing personal health advice to anyone who's online. So it is very much a personal decision. But the things to take into consideration when you're making that decision is, what is your risk of being exposed to monkeypox while you're away? As in, what is your purpose of travel? You know, if you're doing something that's unlikely to expose you to monkeypox while you're away, then probably don't bother. If you think, you know, I've got some things planned that are very likely to put me in contact with monkeypox, then I think it's worth considering. And that will clearly depend on where you're traveling to, because the epidemic is different in different countries. But what the little caveat I would add to that is that you do need to consider the risk of side effects from the vaccine. And you would need to consider how that would impact your travel plans. And, you know, again, you know, we were worried about the risk of serious side effects, including myocarditis, but again, we haven't seen that sort of bear out. So previously, what I advised people was make sure that have a look at your travel insurance policy, because you might void your travel insurance policy in terms of not completely void, but they might not cover you for healthcare associated with a health intervention that you took overseas. because that might not be covered by that particular policy. So I don't think that's as much of an issue now, as in we've had more experience with administering the vaccine, and it seems to be quite a safe vaccine. But just keep it in mind.
Okay. Another vaccine question. You've touched on the fact that the monkeypox virus is an orthovirus, smallpox. At one point, especially people who maybe are a little bit older, may have previously received a smallpox vaccine. Do they have any level? Do we know if they have any level of protection? And does this affect that regimen of 1 to 2 shots with the more modern vaccination?
Yeah, great question. So yeah, Australia routinely vaccinated people until 1980. That's when it was stopped. So some people will have had a vaccine. If you had a smallpox vaccine previously, it would have been the ACAM 2000. And the reason you'll know that you've had a vaccine is that you'll have a scar on your arm. So the ACAM 2000, which was the second generation smallpox vaccine, was a live virus that was able to replicate, and as we mentioned earlier, was associated with significant side effects. But one of the effects was that it would cause sort of a pussy, boily thing on your arm, a bit nasty looking, that leaves a scar. So people who've had smallpox vaccine will have this sort of divot over the deltoid, so here. And so if you don't have that, then you didn't have the smallpox vaccine. If you've had the smallpox vaccine, the ACAM 2000 previously, then you will only need a single dose of the MVABN vaccine, because that should be enough to boost up your immunity, because you will have some residual immunity from the original smallpox vaccine.
Is there a way to test existing immunity that you might have from a previous one?
Look, you could. So you could do antibody levels. Currently in Australia, none of the labs yet have a test for antibody levels on a blood test for smallpox or monkeypox, but it's currently in development. The main reason for developing this test is to help in the workup of people who may have monkeypox infection. But you could feasibly use it to check for immunity. I don't think you would really bother in reality. If you've got the scar, and the reason I say that is the second generation smallpox vaccine, even though it came with significant problems in terms of side effects, it was extremely good at producing an immune response and producing a long-lived, long-lasting immune response, because it was a live virus. So you can assume that if you've got the scar on your arm from the old smallpox vaccine, you will have some level of antibodies residual in your system. May not be enough to prevent you from getting monkeypox completely, but certainly sufficient for you to only need a single dose of the MVABN vaccine.
I am aware that we are running out of time. One last question around, because as a lot of folks know, sometimes you can get a vaccination, but you can also get the disease. If you get monkeypox and you recover from it, do we know anything with regard to immunity towards recurrence?
Great question. Just lots of great questions tonight. So again, it's a bit of an unknown, given that this is a new outbreak. I'm not aware of anyone getting monkeypox twice. And I would also say that given that we prevent this infection with vaccines that consist of virus, that's literally what they consist of. Very different from, say, coronavirus vaccines. So these are vaccines that consist of actual whole virus particles, and the amount of virus you're exposed to from a natural monkeypox infection is much higher than the amount of virus you're exposed to from an immunization. So I think it's reasonable to say that if you get monkeypox infection, you should have immunity for life. Which again is, and this is really important, and I think again, this is a reason for hoping there's light at the end of the tunnel with this epidemic, that unlike with, say, COVID, people aren't going to be at risk of multiple infections over time. Eventually, hopefully, this thing will burn itself out, in that the people who've had monkeypox infection will be protected from repeat infections, and hopefully we'll be able to vaccinate large numbers of people to prevent lots of other infections.
Okay, I'm going to try to do a couple really short ones here.
Go for it.
When you say people living with HIV with regard to vaccination, are we talking about all people living with HIV, or do like low CD4 counts, is that a factor?
It is a factor. It's a factor in terms of vaccine effectiveness. It's not a factor in terms of vaccine safety. So the cutoff that's being used in looking at this data is a CD4 count of 200 or less. So it's thought that if you have a CD4 count over 200, then you should have a good response to the vaccine. If you have a vaccine, if you have a CD4 count less than 200, then you may not have as good a response to the vaccine. And there's currently work ongoing looking at, do we need to provide, say, further doses for people who've got a really low CD4 count? Sorry, that was a bit of a wishy-washy answer, but yeah, I guess to put it in a nutshell, the vaccine is safe for everyone, regardless of whether you're living with HIV or not, and regardless of what your CD4 count is. But if you've got a low CD4 count, as in less than 200, then you may not produce the same level of antibodies that you would otherwise, which may mean that you're not as protected against monkeypox. And we're not yet sure, I think, what we do with that, whether we offer those people further doses beyond what is currently the recommended 2-dose schedule. What I think is important, though, that as a community, again, we need to think about what we can do to stop this epidemic so that we can protect all the members of the community, particularly the members of the community who may not mount a sufficient antibody response to the vaccine.
We did have a question here that I thought was a bit of a curveball. I'm going to ask you. Before we were talking about the fact that we talked about the president's seminal fluid, and this does really seem to be, even though it's not classified as sexually transmitted infection, sex really is at play here. And you were talking about, we all kind of know creative ways.
I'm calling it a sexually transmitted infection.
And fair enough. And so we should, I think, at this point. Someone threw a curveball here. Is it found? What about water sports or piss play? Because in that instance, you're sort of using similar channels. Do we think that might pose a risk?
Oh, great question. Have you seen any data on this?
I haven't seen any data on it, but
Sorry, I'm getting phoning a friend.
You've got a workroom of think tanks to your off screen here. I love this. Okay.
No, I've not seen any data on it, but again, my inference or my understanding would be it would depend on the context. Like if it's like piss play or any kind of play that was really controlled, clothes on or leather or latex or something that involved less skin-to-skin contact. But if it was any kind of like water sports or piss play that still involved.
No, but the question is specifically around piss play, as in, is the urine itself likely to be contaminated? And I don't know, to be honest.
Is there like a viral load in the
urine? Yeah, exactly.
Oh, no, I haven't seen any data.
I haven't seen any data on analysis of urine as to whether there might be virus in urine. I guess important to point out that if you're engaging in piss play and, presumably you might have been a bit excited in the lead up to pissing on someone, there could be some pre-cum in the urethra, and the pre-cum could certainly contain monkeypox virus. And of course, that pre-cum would come out with the first part of the urine stream. So I think there are factors at play. I guess what I'm saying is I think piss play would be a lower risk activity, but I wouldn't be comfortable to say that it would not pose a risk of monkeypox transmission.
The CDC is still researching whether it contains in urine.
There you go.
They're still researching it, so I guess I'm right in not knowing.
And that's I guess a bit of a takeaway is there is a lot of, and you've prefaced a lot of this by saying this is kind of what we, this is what we understand so far, and it is a movable feast. For folks that are tuned in, there's a lot of people that have asked about questions with regard to eligibility criteria. All that criteria is posted on the Thorne Harbour website, thorneharbor.org/monkeypox. Also to watch this space, because as we touched on with this, with the remaining stock that's out there, if guidelines change around the application of the vaccine, we may see, as you said, being able to get vaccine in more arms with a really reasonable efficacy rate, at least for that first shot.
Well, it looks like it's as efficacious.
Yeah, perfect. Yeah. Well, then that's what we want, I guess, if we're going to try to maximize the supply. Folks can stay abreast of that on the Thorne Harbour website and our social media. For those the people that I've asked as well, the recording tonight we should have available, if not immediately tomorrow. We hope to have it up by the weekend, just to clean up the beginning and end, so that folks that tune in later don't have to sit through the initial part where I'm waiting for all the participants to come in and all that good stuff. And we'll link it into those resources. Vincent, thank you so much. Did you have a parting thing?
Yeah, could I say one more thing, please? And I think this is particularly important for Victoria. And Victoria is in a bit of a different boat from New South Wales, in that about half of your cases appear to have been locally transmitted, whereas in New South Wales, we've only so far had one case of local transmission. So I think partner notification is going to become very important in this. And I think as part of that, when we're all looking after each other in the community, is we probably do need to be looking at keeping contact details of people that we've had sexual contact with. Of course, if you've had a grinder hookup and then the person you've hooked up with blocks you, then that really can be a bit of a difficult situation in terms of trying to find a way to contact them to let them know that they need to get tested for monkeypox. So perhaps we need to think about, keeping a diary and keeping contact details of people we've had sex with. And as the final point, I guess, is as I talked about symptoms before, as in what to look out for and when to seek medical advice. I just think it's really important that people are aware of that. And I guess to reassure people is that there's a lot of effort in the health sector to ensure that people are not stigmatized as a result of monkeypox infection. There's as in the health sector is acutely aware that people need to be supported through what is a difficult time. That's probably it.
One last question. We've had a lot of people come through. There have been so many questions and we haven't been able to answer all of them. We might be doing another forum to kind of pick some of those up. But I guess, Vincent, coming back to the aspect around you've said, look, really what we're dealing with here is a sexually transmitted infection. With regards to going out to venues, if those are dance parties, if they're not having sex, should people be staying at home and isolating, or should we be able to kind of go out there and do those regular activities with a reasonable level of confidence, provided we're not having sex with one another during
So are you talking about people who have monkeypox or just in general?
No, people just in general.
Okay.
If, obviously, if someone has a diagnosed case of monkeypox, you do have to isolate. And I believe the current guidelines are at least 3 to 4 weeks.
Yeah,
I think.
So the current isolation guidelines, I don't want to preempt what local governments do. And again, it's different in Victoria from New South Wales. But there is currently consideration about what those isolation guidelines should be, given that it's becoming clearer and clearer that this is a sexually transmitted epidemic rather than a close contact or airborne or respiratory droplet epidemic. So I think those guidelines will change, and the recommendations for isolation will change, hopefully. That's one point. But to answer your actual question, I don't think at this point people need to change their life in general and stop going to music venues or dance parties. I don't think, as I've said a few times, I don't think there's sufficient evidence to say that there's a large amount of transmission at those events. We're really seeing this I'm seeing this, and I think increasingly everyone in the health sector is seeing this as a sexually transmitted epidemic. So it's really more about looking at what is your potential risk for sexually transmitted monkeypox? What can you do to mitigate that risk as much as possible in hopefully the short to medium term? And hopefully then we can all come at the end of this, hopefully well before World Pride comes along, we can have some sense of normality again.
Vincent, thank you so much for your time tonight. Everyone, thank you for attending. And as we said, we'll make the recording hopefully available before the weekend, but stay tuned into Thorne Harbour socials and the website for up-to-date information as this continues to evolve, and especially around vaccine access here in Victoria and further afield.
Brilliant. Thanks so much for having me.
Thank you. Have a great night, everyone.
You too.